Hello, everyone. Hope you're having a good time. Yeah. So like you said, I am the structural heart navigator, one of them that works here at Sanford Fargo. And kind of what our job is we are the coordinators of care. We are your initial contact. So we get these referrals from either your primary or your cardiologist. And we're going through all your information. We're getting all the studies and testing that has been done. And then we are the ones that are your first contact. So we call you, we get you in for your appointments, get you through the rest of the testing, get you set up for surgery if that's what the case is, and just kind of keep you rolling through that process. And we are one contact for you that you can call. So we've had some really good talks today, and Dr. Wind talked about this a little bit, about shared decision-making and the heart team. So that is what mine is going to be on. And we talk about the importance of it. So, cancer care and solid organ transplant programs have, it was driven by a need to bring together multiple specialists to deliver highly individualized care and treatment protocols. So the use of this cardiovascular multidisciplinary team, we call them the multi-D team, was first applied in the Syntex trial, in which a cardiac surgeon and an interventional cardiologist were required to document the equality between either coronary artery bypass surgery, which is open heart surgery, or having a percutaneous coronary intervention, which is called PCI, like stenting. The trial demonstrated then to the wide audience that the feasibility and value of a team approach between cardiologists and cardiac surgeons in modern practice was very useful. In the trials leading to the approval of the TAVR, that transcatheter aortic valve replacement, by the FDA, patients were then required to be assessed by both the cardiologist and a cardiac surgeon. Thus, it further fostered the collaborative decision-making model that was ushered in by that Syntex trial. Since then, the multi-D heart team has received these, they're called Class 1 recommendations from the ACC guidelines in both the United States and European guidelines for valvular heart disease. This has also been further, so CMS is that, it's called the National Coverage Decision, where for payment purposes, they also have said that a multi-D team evaluation is a requirement for for them to cover it, for having payment. So kind of the role of our team. Right now, so our role is really to evaluate the severity of that aortic stenosis, which, like Dr. Farkas has talked about, we use the echocardiogram. There's multiple other ways of testing that we use to do this. We then determine which, if any, interventions are appropriate and discuss the risk, benefits, and alternatives of these treatments options with the patient. Initially, TAVR was only available to those older patients that were at prohibitive or surgical risk. In that setting, the heart team's main role was to evaluate that anatomical candidacy due to the limitations of the TAVR technology with regards to available valve sizes and modes. So that was the very first patients that started coming in for us. However, as the TAVR devices have improved, and studies have shown that TAVR is both a safe and effective treatment strategy when compared with surgical aortic valve replacement, for patients of all levels, clinical decision-making has now become, the use of this has become much more complex. For patients presenting with severe aortic stenosis requiring an aortic valve replacement, the first major decision has to be, which way are we going to do this? This is kind of a good picture of that assessment pathway of when you get that first TAVR referral from either your primary or your cardiologist. You get to that first appointment with the initial assessment with one of the cardiologists, the interventional ones, and then kind of figuring out what we need to do from there. TAVR has many faces, so that's why this decision-making has become much more complex. It's not your typical very old patients anymore that can't have surgery. The risk factor has decreased where it's low, intermediate, and high risk. So you can have your 65-year-olds, you can have your 99-year-olds. We just actually had a 99-year-old not that long ago. He was amazing, and when I called him to do his post-op check, he said, "You need to call me back, I'm playing bingo." I said, okay. So the ACC, or American College of Cardiology, has set out these guidelines that were updated in 2020 to help our heart team with that decision. Kind of to break it down a little bit, open heart surgery, or SAVR as we call it, has been recommended for patients that are younger than 65 or that have a life expectancy over 20 years. SAVR is also still recommended as the preferred modality over TAVR for those in whom there's either vascular or some sort of other anatomical feature that is unsuitable for TAVR. There's going to be such things as low coronary heights. There's other reasons too where we aren't able to use our valve technology for that. For patients that are at prohibitive risk or that have a life expectancy of over 12 months, patients at lower intermediate risk, if they're over 80, or if you have less than 10 years of life expectancy, that's when TAVR has been recommended. Now, although these guidelines are able to offer a clear framework regarding these roles for certain patients, for many patients, the guidelines have become less definitive and even more conflicting. This is from the 2020 guidelines for ACC that gives you a little picture of kind of where that pathway lies. But as we all know, not everybody fits into these perfect little boxes of what we can do with them. Especially those age ranges between 65 and 80 that are either low or intermediate surgical risk. So in this population, the guidelines say you can do either or. Okay, well now what do we do? That's why you enter the heart team. This was one of our pictures of the heart team. This was our 1,000th TAVR that we did, which was actually a couple years ago now. Currently we're over 1,700 cases that we've completed at Sanford. Multiple different, people are in this room. That's only even a fraction of whoever is in the room at the time of these cases. Who is the heart team? This is going to vary from hospital to hospital, but usually your core group is going to be your interventional cardiologist, like Dr. Sharma, your cardiac surgeons, which will be like Dr. Bajwa, who will be speaking next. Dr. Dyke is one of our other surgeons, and Dr. Newman. You'll have your valve clinic coordinators, anesthesia, referring physicians, the patients themselves, and there's many more people, such as the echo techs, hi guys, that help us as well. Gives you a little picture. Imaging specialists, anesthesiology, they're really big factors in our cases as well. So once a patient has been referred from either their primary cardiologist, now our job is to evaluate that patient's surgical risk. We also need to counsel them on how long is that valve going to last. Like we've talked about, if you have a mechanical valve, that valve is usually a one and done. If you have a bioprosthetic or a tissue valve, there is a timeline how long that valve will last. You need to talk about the risks and benefits of both. And then, such as now with that low-risk patient population that is coming into play, we really need to start involving those decisions about what happens when that valve fails. What is our next step? So when we're doing our initial procedure, we've also thought 10, 15 years down the road, and what are we going to do at that point? Patients have now also become a very integral part of that heart team, as they have very different decisions for themselves about the varying risks associated with either open heart surgery or having that less invasive TAVR, such as quality versus quantity, or there might be social issues. Maybe they're alone and they have nobody that can take care of them after a surgical procedure. With the recent TAVR studies that have come out that compares the TAVR to a SAVR and showing similar outcomes, the heart team now becomes more important than ever in making decisions that not only impact a patient's life now, but in the future as well. So some of the benefits that we've discovered with having that heart team involved. So beyond the proposed benefits to individual patients, the heart team may also be beneficial to other clinicians in the health system itself. Medicine in the cardiac patient population has become much more complex due to the increasing variety of therapeutic options and the higher level of comorbidities that patients now have. The heart team allows that pooling of knowledge and expertise, ensuring that the treatment is tailored to the patient using the latest evidence that we can have. The combination of this allows the team for optimal management of complicated clinical scenarios while also furthering innovation. This opportunity to interact and collaborate with other colleagues to provide optimized care can improve knowledge, skill sets, and job satisfaction for individual clinicians as well. Dr. Dyke is one of our heart surgeons that is on our team, is very engaged with the residents at UND, and especially in regards to research. And so usually every year we get a couple of the research students, so the residents that come in, and he'll pick some sort of project. Usually it's TAVR related. One of them that he did was showing that patients that have COPD, chronic obstructive pulmonary disease, still benefited from having that TAVR procedure versus not having it, which has led to better decision making from our team and just other clinicians as well, letting them know that yes, they still will be potentially short of breath, but they do feel better and it kept them out of the hospital. At the health system level, that heart team approach can lead to more effective use of healthcare resources as well. Economic reviews that they've done have demonstrated that the overall cost effectiveness of having TAVR compared to SAVR has improved over time. Although TAVR was initially more expensive than SAVR, TAVR has now been shown to be the dominant strategy for treatment of patients, even at low and intermediate surgical risk, when compared with SAVR, and it's mainly based for shorter hospital stays. Most of our patients are in for one night. They're in the hospital and they're out early the next afternoon versus the 5 days or more that it can be with open heart surgery. Other benefits can be that they allow more intricate and better coordinated treatment plans. Like I said, as they get more complex patients, it becomes such as like we develop hybrid plans. If they have coronary artery disease where they can't put stents in place, do we do a hybrid approach where they can do open heart surgery and fix the vessels in your heart, but maybe we do the valve procedure at a later time. It minimizes that fragmented decision making and improves coordination of care. It also facilitates the shared decision making with patients and families and really gets them involved in asking them what do they want, how do they want to see their life. It improves the timeliness and consistency of decisions when there's multiple providers that are going to be involved, increasing that satisfaction for both patients and physicians. With that being said, the most benefit does come from having also a functional heart team. There is no I in team. In order to have the best possible patient outcomes, the multidisciplinary heart team needs to function as just that. We have to be a team. We need to be able to share the same goals. We have to put egos aside, use their individual skills and knowledge to the best of our ability, and be respectful to one another in the process. There are times that patients that need to be discussed and decisions made about the next steps with a patient, such as, do we do CABG and an AVR? Do we do TAVR and a PCI? Do we do that hybrid approach? Or the harder decision, do we do nothing? Is this patient at end of life where there's really not going to be any good options that we need to have that discussion as well? Having a functional heart team makes for easier and better decision making in that process. I am a little biased, but the structural heart team at Sanford does a really great job at this. Don't get me wrong, we have a lot of very strong personalities that can make for some very challenging discussions, but in the end, we're still able to do what's best for our patients. And why is it all worth it? Some fun pictures. The landscape of valvular treatment has changed dramatically in the past decade and continues to evolve rapidly. The rise of these transcatheter valve technologies have shifted treatment paradigms, and the decision to pursue either TAVR or SAVR for aortic stenosis has become increasingly complex, thus requiring an accurate assessment that extends beyond simple eligibility for this particular procedure. The multi-D heart team becomes a valuable tool in the management of structural heart disease and continues to play an essential role in the care of these patients with aortic stenosis. And this is just a fun little picture that we did. We were doing a Photoshop, and this is just part of our team dynamics.
Getting photobombed?
Getting photobombed, yes. Thank you.